Good morning, friends. Today we will see about pigments and intracellular accumulations. First, we will see about intracellular accumulations. Intracellular accumulation of substances in abnormal amounts can occur within the cytoplasm or nucleus of the cell. This accumulation of substances in mild degree causes reversible cell injury, while more severe damage results in irreversible cell injury. Such abnormal intracellular accumulations can be divided into three groups. Accumulation of constituents of normal cell metabolism produced in excess, for example lipids, proteins or carbohydrate. Second is accumulation of abnormal substances produced as a result of abnormal metabolism. And third one is accumulation of pigments. First is fatty change or intracellular accumulation of fat. It is common in the liver but may occur in other tissues like heart, skeletal muscle and kidneys. Fatty liver. Liver is the commonest site for accumulation of fat because it has central role in the fat metabolism. Depending upon the cause and amount of fat accumulation, fatty change may be mild and reversible or severe, producing irreversible cell injury and cell death. Etiology. It may result from one of the two types of causes. One is conditions with excess fat like obesity, diabetes mellitus or congenital hyperlipidemia. And second is liver cell damage due to alcoholic liver disease, starvation, protein calorie malnutrition, acute fatty liver in late pregnancy, hepatotoxins or drug-induced liver cell injury. Pathogenesis. Lipids as free acids enter the liver cell from either of the following two sources: from diet as chylomicrons and free fatty acids, and from adipose tissue as free fatty acids. Most of this free fatty acid is esterified to triglyceride by the action of alpha glycerophosphate, and a small part is changed into cholesterol, phospholipids and ketone bodies. While cholesterol, phospholipids and ketones are used in the body, triglycerides are converted into lipoproteins, which requires lipid acceptor protein. These lipoproteins are released from the liver cells into circulation as plasma lipoproteins like LDL or VLDL. Intracellular accumulation of triglycerides can occur due to defect at one or more of the following steps. First is increased entry of free fatty acids into the liver, increased synthesis of fatty acids by the liver, decreased conversion of fatty acids into ketone bodies resulting in increased esterification of fatty acids to triglycerides. Fourth is increased alpha glycerophosphate causing increased esterification of fatty acids to triglycerides. Fifth is decreased synthesis of lipid acceptor protein resulting in decreased formation of lipoprotein from triglycerides. And sixth is block in the excretion of lipoprotein from the liver into plasma. In the case of liver cell injury by chronic alcoholism, many factors are involved, which includes increased lipolysis, increased free fatty acid synthesis, decreased triglyceride utilization, decreased fatty acid oxidation to ketone bodies, or block in lipoprotein excretion. Morphological features. Grossly, the liver is enlarged with a dense glistening capsule and rounded margin. Cut surface is pale yellow to yellow and greasy to touch. This figure showing fatty liver. Left side figure shows enlarged liver with a dense glistening capsule and rounded margins. Right side figure shows cut surface of fatty liver, which is pale yellow to yellow. Microscopically, the characteristic feature is presence of numerous lipid vacuoles in the cytoplasm of hepatocytes. It appears as non-staining vacuoles in H&E stain section because fat gets dissolved in the alcohol. These vacuoles are initially small and present around the nucleus. With progression of the process, the vacuoles become larger, pushing the nucleus to the periphery of the cells. Fat can be demonstrated by fat stains such as Sudan dyes and oil red O. Figure on the right side shows normal histology of liver, showing portal triad, central vein, and cores of hepatocytes radiating from central vein to the portal triads. Right side figure shows histology of fatty liver, showing numerous hepatocytes containing lipid vacuoles. Cholesterol deposits. Intracellular deposits of cholesterol and its esters in macrophages may occur when there is hypercholesterolemia. This turns macrophages into foam cells. The examples are fibrofatty plaques of atherosclerosis and clusters of foam cells seen in xanthomas and xanthelasma. Stromal fatty infiltration. It is the deposition of mature adipose cells in the stromal connective tissue in contrast to intracellular deposition of fat in parenchymal cells seen in fatty change. This condition occurs in patients with obesity, and two most commonly affected organs are heart and pancreas. Intracellular accumulation of proteins. It may occur in following condition. First is proteinuria. In this, there is excessive renal tubular reabsorption of proteins by the proximal tubular epithelial cells, which show pink hyaline droplets in their cytoplasm. This change is reversible, so that with control of proteinuria, the protein droplets disappear. Second is Russell bodies. The cytoplasm of actively functioning plasma cells shows pink hyaline inclusions representing synthesized immunoglobulin. Third one is in the alpha-1 antitrypsin deficiency, the cytoplasm of hepatocytes shows eosinophilic globular deposits of mutant protein. Fourth one is Mallory bodies seen in hepatocytes. They are intracellular accumulation of intermediate filaments of cytokeratin and appears as amorphous pink mass. Intracellular accumulation of glycogen. Associated conditions are diabetes mellitus. In this, glycogen deposits are seen in epithelium of distal portion of proximal convoluted tubule and descending loop of Henle, in the hepatocytes, in beta cells of pancreatic islets, and in cardiac muscle cells. To confirm the presence of glycogen, PAS staining is used. In the glycogen storage disease, there is defective metabolism of glycogen due to genetic disorders. Pigments. These are colored substances present in most living beings, including humans, and there are two types of pigments, endogenous and exogenous. Endogenous pigments are melanin, melanin-like pigment, hemoprotein-derived pigments, and lipofuscin, while exogenous pigments are inhaled pigments, ingested pigments, and injected pigments. Endogenous pigments. These are either normal constituents of cells or accumulate under special circumstances. First is melanin. It is brown-black pigment normally present in the hair, skin, and choroid of the eye. It is synthesized in the melanocytes with the help of enzyme tyrosinase, which is necessary for synthesis of melanin from tyrosine. Sometimes tyrosinase is present but is not active, and hence no melanin pigment is visible. Figure showing brownish colored melanin pigment. Disorders of melanin pigmentations are generalized hyperpigmentation, focal hyperpigmentation, generalized hypopigmentation, and focal hypopigmentation. First, we will see generalized hyperpigmentation. For example, Addison's disease, chloasma observed during pregnancy and in women taking oral contraceptive, and chronic arsenical poisoning. Focal hyperpigmentation examples are pigmented patches seen in neurofibromatosis and Albright syndrome, Peutz-Jeghers syndrome showing focal perioral pigmentation. Melanosis coli showing pigmentation of the mucosa of the colon. Melanotic tumors, both benign such as pigmented nevi and malignant tumors such as melanoma, and dermatopathic lymphadenitis. Figure showing focal hyperpigmentation. Generalized hypopigmentation. Most common example is albinism. It is extreme degree of generalized hypopigmentation in which tyrosinase activity of the melanocytes is genetically defective and no melanin is formed. These patients have poor vision, severe photophobia, and are highly sensitive to sunlight. Localized hypopigmentation, example leukoderma, which is a form of partial albinism, vitiligo, and acquired focal hypopigmentation can result from various causes like leprosy, healing of wounds, or radiation dermatitis. Melanin-like pigments. First is alkaptonuria. This is rare autosomal recessive disorder in which there is deficiency of an oxidase enzyme required for breakdown of homogenesic acid, which then accumulates in the tissues and is excreted in the urine. Urine of such patients, if allowed to stand for some hours in air, turns black due to oxidation of homogenesic acid. The pigment is melanin-like and is deposited both intracellularly and intercellularly and called as ochronosis. Most commonly affected tissues are cartilages, capsules of joints, ligaments, and tendons. Second is Tubin-Johnson syndrome. It is also an autosomal recessive disorder. Here, hepatocytes contain melanin-like pigment in the cytoplasm. Hemoprotein-derived pigments. These are hemosiderin, acid hematine, bilirubin, and porphyrins. First is hemosiderin. It is formed by aggregates of ferritin and is seen by light microscopy as golden yellow to brown granular pigment within the mononuclear phagocytes of the bone marrow and spleen. It can be demonstrated by pulse stain that produces Prussian blue reaction. In this reaction, colorless potassium ferrocyanide reacts with ferric ions of hemosiderin to form deep blue ferric ferrocyanide. This figure showing golden yellow finely granular hemosiderin pigment. Another figure showing Prussian blue stain, which is specific for iron and seen as blue granules. Causes of excessive storage of hemosiderin are increased breakdown of red cells, systemic overload of iron due to primary hemochromatosis, and secondary or acquired causes like thalassemia, sideroblastic anemia, alcoholic cirrhosis, and multiple blood transfusions. Effects of excess hemosiderin are localized hemosiderosis and generalized hemosiderosis. Localized hemosiderosis. This develops whenever there is hemorrhage into the tissues. With lysis of red cells, hemoglobin is liberated, which is taken up by macrophages, where it is degraded and stored as hemosiderin. Examples are the changing colors of februis and brown indication in the lungs. Generalized or systemic hemosiderosis. Systemic overload with iron may result in generalized hemosiderosis, and there can be two types of patterns: parenchymatous deposition or reticuloendothelial deposition. Parenchymatous deposition occurs in the parenchymal cells of the liver, pancreas, kidney, and heart, while reticuloendothelial deposition occurs in liver, spleen, and bone marrow. Causes of generalized hemosiderosis are increased erythropoietic activity. In chronic hemolytic anemia, there is excessive breakdown of hemoglobin and hence iron overload. This problem is further compounded by treating the condition with blood transfusions or by parenteral iron therapy. Second cause is Excessive intestinal absorption of iron, even if intake is normal, and is known as idiopathic or hereditary hemochromatosis, and it is characterized by a triad of pigmentary liver cirrhosis, pancreatic damage resulting in diabetes mellitus, and skin pigmentation. Third cause is excessive dietary intake of iron. This excess of iron gets deposited in various organs including liver, causing pigment cirrhosis. Second one is acid hematine. It is a hemoprotein derived brown black pigment containing heme iron in ferric form in acidic medium. It differs from hemocyanin because it cannot be stained by pulse stain because of formation of complex with a protein, so that it is unable to react in the stain. This pigment is seen most commonly in the chronic malaria and in mismatched blood transfusions. Third one is bilirubin. It is normal non-iron containing pigment present in the bile. Normal level of bilirubin in blood is less than 1 mg per deciliter. Excess of bilirubin causes a clinical condition called jaundice. Jaundice may appear in one of the following three forms: prehepatic or hemolytic, posthepatic or hepatocellular. Excessive accumulation of bilirubin pigment can be seen in different tissues of the body, especially in the hepatocytes, Kupffer cells, and bile sinusoids. Skin and sclera become yellow. In infants, this rise in unconjugated bilirubin produces toxic brain injury called kernicterus. Porphyrins. These are normal pigment present in hemoglobin, myoglobin, and cytochrome. Porphyria results from genetic deficiency of one of the enzymes required for the synthesis of heme, resulting in excessive production of porphyrins. These are associated with excretion of intermediate products in the urine like porphobilinogen, uroporphyrin, coproporphyrin, and protoporphyrin. Porphyrias are of two types, erythropoietic and hepatic. Erythropoietic porphyria, they have defective synthesis of heme in the bone marrow, and these may be further up two subtypes: congenital erythropoietic porphyria, in which urine is red due to presence of uroporphyrin and coproporphyrin, and second is erythropoietic protoporphyria, in which there is excess of protoporphyrin but no excess of porphyrin in the urine. Second is hepatic porphyria. They have a defect in synthesis of heme in the liver. It has three subtypes: acute intermittent porphyria, porphyria cutanea tarda, and mixed porphyria. Acute intermittent porphyria, characterized by acute episodes of abdominal, neurological, and psychotic symptoms. These patients do not have photosensitivity, and there is excessive delta aminolevulinic acid and porphobilinogen in the urine. Porphyria cutanea tarda. It is most common subtypes, and most of the patients have associated hemocytosis with cirrhosis, which eventually develop into hepatocellular carcinoma. Third one is mixed porphyria. It is rare subtype. Patients have combined skin photosensitivity with acute abdominal and neurological manifestations. Lipofuscin, also known as wear and tear pigment. It is yellowish brown intracellular pigment. It is found in atrophied cells of old age and hence the name wear and tear pigment. It is seen in myocardial fibers, hepatocytes, Leydig cells of the testis, and in neurons in senile dementia. By light microscopy, the pigment is coarse, yellowish brown granular, and often accumulates in the central part of the cells around the nuclei. In the heart muscle, the change is associated with wasting of the muscle and is commonly referred to as brown atrophy. Figure showing lipofuscin pigment as yellowish brown cytoplasmic granules. Another figure showing lipofuscin granules in a myocardial fiber in the case of brown atrophy of heart. Exogenous pigments. These are the pigments introduced into the body from outside, such as by inhalation, ingestion, or inoculation. Inhaled pigments. The lungs of most individuals show larger number of inhaled pigmented materials. The most commonly inhaled substances are carbon or coal dust. Others are silica, asbestos, and various other organic substances. These substances may produce occupational lung disease called pneumoconiosis. These pigment particles after inhalation are taken up by alveolar macrophages. Some of these pigment-laden macrophages are coughed out via bronchi, while some settle in the interstitial tissue of the lung and in the respiratory bronchioles and pass into the lymphatics to be deposited in the hilar lymph nodes. Extensive deposition of particulate material over many years provoke low-grade inflammation, fibrosis, and impaired respiratory function. Figure showing black-colored inhaled pigments. Ingested pigments. Chronic ingestion of certain metals may produce pigmentation. Examples are argyria, occurring due to chronic ingestion of silver compounds, resulting in brownish pigmentation in the skin, bowel, and kidney. Second is chronic lead poisoning, producing characteristic blue lines on the teeth at the gum line. Third one is keratonemia, which is yellowish red discoloration of the skin caused by excessive ingestion of carrots which contain keratin. This is a case of chronic lead poisoning showing blue lines on the teeth at gum line. Last one is injected pigments or tattooing. Pigments like India ink, cinnabar, and carbon are introduced into the dermis in the process of tattooing, where the pigment is taken up by macrophages and lies permanently in the connective tissue. The examples are prolonged use of ointments containing mercury, dirt left accidentally in a wound, and tattooing by pricking the skin with dyes. So this is all about pigments and intracellular accumulations. Thank you.